Welcome to an EMS 204 Airway Management. Our first lecture will be Airway and Respiratory Anatomy and Physiology Review. So the respiratory assisted anatomy, again, this will just be a quick review over what you've already learned and what you should have gotten from your anatomy and physiology course. It consists of all the structures of the body that contribute to respiration. Realize that there is a difference between ventilation and respiration. Ventilation being the flow of gases in and out of the body, air, and respiration, when we talk about the term respiration, truly means the exchange of gases, carbon dioxide, and oxygen at the cellular level. What consisted of the upper airway and the lower airway. Basically, the whole response of this is in with the good air and out with the bad air. And always remember rule number 1 of anatomy and physiology, which trumps all other rules, is air must go in and out and blood must go round and round. Any deviation of this is incompatible with life. So the upper airway is located anteriorly and at the midline. So anteriorly meaning at the front of the body, a midline in the middle. For those of you with a review of anatomy and physiology terms. Some of the structures of the upper airway include the nasopharynx, the nose and the nasal cavities, the turbinates. Who can tell me what a turbinate is? We have 3 of them. The turbinates consist of the part that actually circulate that air up in the nasal conch as it comes in to make sure that that air gets humidified and warmed, so that way we're not taking in cold, dry air. Because overly dry air, what happens with overly dry air when we breathe that in? I've probably experienced a nosebleed at some point in time in our life. All right. In addition to that, cold air. What does cold air do? Takes our breath away. I am here joined by some of your fellow classmates, and as you can see, the crickets are chirping. I will not mention any names as to who these classmates are. We do have the nasal mucosa, which are responsible for also producing the mucus, which comes from the goblet cells, which ensures that we don't get the toxins and bad stuff in the air into our nose and into our respiratory tract. And the nasal mucosa is also a very thin lining, which also has a very rich vascular supply underneath, which is why patients that have hypertension and other chronic diseases, as well as dry air, can also many times cause them to have epistaxis. And then we have our olfactory receptors that are located in there to help us with distinguishing smells and odors, which also aid with our taste. Behind that we have the oropharynx, which is the oral cavity, the mouth. Is there obviously, which intakes both air and food. The tongue, which helps with mastication or the chewing of the food, and our jawbone, which helps with communication and also mastication. Behind that we have the pharynx, which is where the nasopharynx and the oropharynx connect. The laryngopharynx is also oftentimes known as the hypopharynx. And when we start to talk about endotracheal intubation, we will talk very heavily about the hypopharynx because the hypopharynx is oftentimes places where we will have our tube disappear into and we'll discuss. But it is the inferior-most passage of the upper airway. Realize that just behind the trachea we have the esophagus. So the esophagus is posterior, meaning it is closer to the spinal cord, and the trachea is in the anterior aspect, meaning the front. That's why if you've ever heard of cricoid pressure, when you put cricoid pressure on someone, you are actually putting pressure on the esophagus, which is also compressing the esophagus in between the trachea rings and the vertebrae. We have the epiglottis, and what is the function of the epiglottis?
To keep everything but air out of your lungs.
Yeah, it's a flap that's going to flap closed to keep everything out of the lungs that doesn't need to be there. So when we swallow, like food, liquids, and other things, it's going to flap closed typically and prevent those bodies from entering into the airway.
That's the mammalian dive reflex, right?
Well, the mammalian dive reflex, that is one aspect of the mammalian dive reflex, is when we get splashed with cold water in the face, or if we dive into cold water or whatnot, it's going to cause an immediate spasm of that epiglottis and a laryngospasm as well to prevent water from going into our lungs. Protective mechanism for us, especially in small children. The glottis obviously is the location where air enters into the trachea itself. So you can see on this next slide here the upper airway and the upper respiratory tract. You can see the nasal cavity. We have the nasal conch and the turbinates or the meatuses, the superior, middle, and inferior. The conchae has a superior, middle, and inferior aspect as well. Notice that just right above the nasal cavity we have the cribriform plate and the ethmoid bone, and you can notice that that bone is very thin there. That's why oftentimes when we talk about nasopharyngeal airways, nasotracheal innovation later on, we're concerned with patients that potentially have a basilar skull fracture, because as you can see, that bone could fracture very easily, and you could potentially place your airway adjunct into the skull or into the actual cranial vault. The nostril there, we can see back behind there we have the nasopharynx, which we have the pharyngeal tonsils. What is a tonsil? Can anybody tell me what a tonsil is?
It's a gland.
Oh, okay, we're in a gland. We're in the right ballpark there. At least somebody didn't say that it's just something that causes a bunch of problems for us. It's lymphatic. It's part of the lymphatic system. It's actually lymph nodes that collect there, and that's why oftentimes whenever patients that have their tonsils have problems because they collect bacteria, other things, they swell, they get inflamed because of the white blood cells and the other lymphocytes that are there. That's why they tend to cause patients problems. We have the opening of the pharyngeotympanic tube there, or the Eustachian tube. What is the Eustachian tube? Have you heard of the Eustachian tube before? So how many of you guys have had an ear infection before and you've had stuff draining into the back of your throat? Okay, or you have your ears get stopped up and you have that change in pressure that happens and your ears pop, or you've experienced your ear pops even if you don't have an ear infection. It's the Eustachian tube. It's an air opening that goes down directly into the nasopharyngeal airway area. That's going to help to open everything up. Then we have into the mouth, the hard palate and the soft palate. We have the tongue there, obviously, and we have another tonsil right behind the tongue, the lingual tonsil. And you can see right below that area we have the hyoid bone. What makes a hyoid bone unique?
It doesn't touch any other bone.
It's not connected to any other bone. Okay. What's the function of the hyoid bone?
Absolutely nothing.
Doesn't have any connection, any responsibility. The only thing that it really does kind of help with a little bit with is with the structure of the larynx. But really, truthfully, it really doesn't have much function other than that. You could not have your hyoid bone and you would be perfectly fine.
It tells if somebody gets strangled or not.
Yes, does. Somebody's been watching way too much CSI, but you're absolutely right. We have the oropharynx back there, and you can see that we have the palatine tonsil. Down below that we have the laryngopharynx. We have the larynx there, the epiglottis, vestibular fold. We have the thyroid cartilage, the vocal fold, and the cricoid cartilage. And then you can see that the trachea lies in front of the esophagus, so the trachea is in the anterior aspect, and the esophagus is in the posterior aspect. So that's the respiratory tract. So when we talk about the lower airway basically starts when we get to the Adam's apple or the thyroid cartilage. Boys and girls both have thyroid cartilages, and so they all have Adam's apple. Realize some patients it's more profound than others. On a big guy like me, my Adam's apple is not going to be very prominent. However, you get to someone that's much thinner, smaller, more leaner, you're going to see that their Adam's apple is very prominent. But it is the most anterior portion of the larynx. Tiny muscles open and close the vocal cords, and that is what causes sounds to be created as the air is forced past them. The cricoid cartilage is just below the thyroid cartilage. The cricoid thyroid membrane is formed between the cricoid cartilage and the thyroid cartilage. It's going to be an important place for you to learn, because obviously that is where the cricothyrotomy is performed. Everybody will take time and real quick find your Adam's apple, find your knots there. If you go just below that, and you'll feel the cricoid cartilage. So in between there, that little indentation that you feel is a cricothyroid membrane, and that is where you would perform a cricothyrotomy. All right, it's a little indentation, and we will play with this in lab when we get into lab a little bit later on. So you can see on this diagram here, this guy has a very prominent Adam's apple and very prominent anatomy. You can see the body of the hyoid bone. If you just go from your chin and go back a couple of inches, you can see that the hyoid bone is right there. Then you have the laryngeal prominence, or the Adam's apple, and then you have the cricoid cartilage right below there. So in between that would be the cricoid cartilage. We have the sternal head, the clavicular head, clavicle, and the jugular notch. And we all find the jugular notch there, and that's the spot for you, Derek, where you're always wanting to use the bit, or which IO is that you want to use? The fast IO. Yeah, that's what we're talking about there. So there you can see a little diagram and look at that just a little bit. Again, this should all be reviewed for you. The lower airway consists of the trachea, which is about 5 inches long. It's semi-rigid. It's got the cartilage rings that are half cartilages. They're open in the back. Anybody know why they're open in the back?
So your esophagus.
Allow for esophageal connection. They are semi-rigid to prevent further collapse, so they don't collapse on themselves. The carina. The carina is located about the 5th thoracic vertebrae. So if you go to T5, go front, that's where you have the carina. What is the carina?
Where the esophagus branches into the bronchioles.
That's where our trachea branches into our bronchioles. Our main bronchus. We get our right main stem and our left main stem bronchus. We have a bronchial tree. We have the primary bronchus, the secondary bronchus, and the tertiary bronchus. Now, when we talk about our primary bronchus, we talk about the right main stem and the left main stem bronchus. When we're looking at that, how many of you have ever heard the term right main stem? Right main stem 2, or something in those lines. What we talk about with a right main stem is the fact that when you look at the anatomy, and we'll see a diagram here in just a minute, but what you'll notice is the right main stem is a straight shot down, and the left main stem's got a little bit of a curve to it when it curves off. So it's very easily, when you're intubating someone, that you'll actually put this tube into the right main stem. So what you want to do is you want to be cautious of that, cognitive, but you know past the carina when you place that tube. Now, we'll talk about that when we get into tracheal intubation, but it's an easy fix. But that is what the difference is between the right and the left main stem bronchus. I have another little picture here, and we're going up a little bit higher than the bronchus, obviously. We're going here right at the opening of the trachea. And this is what the anatomy that you would basically see whenever you're getting ready to intubate someone. It is imperative that you memorize all of this anatomy, and you know all of this anatomy and can call it out by name. You need to be able to recognize when you're looking in at the root of the tongue. You need to be able to identify the epiglottis. You need to be able to identify the true and false vocal cords. You need to be able to identify the cuneiform cartilage, the corniculate cartilage, the trachea itself, and the glottic opening. All of these are things that you need to identify and be comfortable with. That way when you're doing laryngoscopy, you can identify these landmarks, because it is imperative that you be able to find these things. So start looking at this diagram now and memorizing the names on this diagram. It'll come in handy when we get into the lab, I promise you that. So our lower airway, continuing on, as we said, we have our primary, secondary, and tertiary bronchuses. We have our bronchioles, which are the smaller airways. And then we get into our alveolar ducts, which lead directly to the alveoli. What makes the alveoli so unique? Alveoli are the only place where gas exchange takes place. So everywhere else in our airway, upper, lower airway, we don't have gas exchange taking place. It's just there. The air just sits stagnantly. But in the alveoli, this is where we're actually going to have the exchange of carbon dioxide and oxygen taking place. The alveoli is covered with, has a layer of lining of surfactant inside. The purpose of the surfactant is to prevent atelectasis. What is atelectasis? The collapsing of the alveoli in on themselves. So that prevents it, because it's very hard once the alveoli completely closes down. It's very hard to open it back up. Think about a balloon. It's very hard to first get that balloon. When you first start blowing on the balloon, it's hard to get it to start. But once you get it to start, it's pretty easy. Same thing with atelectasis. When we talk about those, we don't want our alveoli to completely close down. Around the alveoli, we have the alveolar capillary membrane, and that is where the actual exchange of CO2 and oxygen is going to take place. So here on this next slide, you can see the bronchioles breaking off into the alveolar ducts and the actual alveolar, the alveolar sacs. And you can see the alveolar sacs are like a bunch of grapes. That's what they are. And each alveoli being a grape. There's a whole group of them together. But realize surrounding these guys, we have a very, very rich vasculature. The capillary membranes there that are going to help and allow us to pick up that oxygen or drop off that CO2 so that we have adequate gas exchange taking place. So we talk about the lungs themselves. We have the right lung and we have the left lung. Realize the right lung is composed of 3 lobes and the left lung is composed of 2 lobes, right? Why does the left lung only have 2 lobes?
For your heart.
We're going to have room for the heart. Realize surrounding the lung we have the visceral pleura, which covers the lungs, and on the outside of that it folds around and it creates the parietal pleura, which is a membrane that covers the visceral pleura covers the lungs themselves. The parietal pleura covers the inside of our thoracic cavity. When we talk about patients that have like a pneumothorax, something along those lines, that's what we're talking about air being trapped into, is in this pleural space. I realize, typically speaking, there's not a void or a space in between the pleural space. Usually the parietal and the visceral pleura come in constant contact with each other, but they can separate out and actually cause a void and cause problems for us. The lungs themselves receive deoxygenated blood from the right ventricle via what highway?
Pulmonary.
Pulmonary artery. Pulmonary artery takes blood from the right atria and dumps that into, or from the right ventricle rather, and dumps that into the lungs so the gas exchange can take place. And then we have oxygenated blood returning to the left atria via the pulmonary vein. So you can see a picture of the lung there. We have the superior lobe of the right lung. Realize that the superior portions of our lung actually can extend to just above our clavicles. They're hanging out right above the clavicles here. We have our trachea, we have our superior lobe of the left lung, our bronchuses, you can see that. And you can just see the picture there of how those, we have our primary bronchus, secondary bronchus, and our tertiary bronchuses, and then they branch off even further to the bronchioles, eventually leading into the alveoli. So, when we talk about muscles of breathing, we have diaphragmatic contraction. And diaphragmatic contraction is what causes us to bring air in. It works based off the principle of negative pressure. When our diaphragm contracts, it creates negative pressure, which, for lack of a better term, creates a vacuum. And that vacuum is what's going to suck the air in. Realize we have a pressure of 760 millimeters of mercury if you're at sea level. That's the atmospheric pressure. All right. If I create a negative pressure, it's going to draw that air in until we get to equilibrium, and then we're going to go a little bit past that point, and then the diaphragm is going to relax, and at that point in time, air is going to become passive. Realize the inhalation or the contraction of that diaphragm that causes the negative pressure is an active process, which means it's going to require energy. Remember, exhalation itself should not cause any energy or cause utilization of any energy because it is a passive process. The diaphragm cannot be seen or palpated. It has smooth and skeletal properties. What do I mean by the fact that it has smooth and skeletal properties?
You can breathe when you want to, but you're going to breathe when you need to.
You can breathe when you want to, but you're going to breathe when you need to. That's absolutely right. You can hold your breath and paralyze it and not make it work until you pass out. And as soon as you pass out, then it's going to go back into smooth muscle control. Okay? It attaches to the costal arch and the lumbar vertebrae, and we have phrenic nerve control. And the phrenic nerve is what's going to cause it to actually contract and create that negative pressure and draw that air in. We also have our internal and our external intercostal muscles, and we have our intercostal nerves. We have our abdominal muscles that are used as well as our pectoral muscles. All of these muscles are going to aid us in breathing. So when the diaphragm contracts and the chest wall expands, we create negative pressure. There's room for air to be drawn in and sucked in. Again, this is an active process. It's going to require the utilization of energy. When the diaphragm and chest wall relaxes, pressure equalizes out, and then passively air is going to escape out and get back into the atmosphere until the whole cycle starts all over again. It should not require us to exhale or forcefully exhale to get rid of air, though. If we're doing that, we're using energy at that point in time, and it becomes an active process. But it's normally a passive process. Like when we talk about COPD patients, like emphysema patients, patients that are having exacerbations of their asthma, these patients will be forcefully exhaling because they're having difficulty with exhaling. So that in and of itself is going to require increased metabolic demands, which cause our patients to tire out and potentially have crash airways later on down the road. What causes all of this to actually happen? What tells us that we need to take a breath in?
It has to do with the buildup of CO2.
CO2. As we build up CO2 in our bloodstream, realize that our normal pH is 7.35 to 7.45, CO2 being acidic. As it starts to build up, we're going to start to get acid buildup in the blood. The body picks up on that through the chemoreceptors, which are located in the medulla and the brain, and also in the aortic arches. These chemoreceptors pick up on that CO2 level, and that is what's going to cause us to take a breath in, so that way we can have that exchange of oxygen and get rid of the CO2. So the primary function of the lungs is to exchange gases, and that's what it's about. That is respiration at its definition. We inhale 21% oxygen at sea level. Right? We inhale 21% oxygen at 8,000 feet. Actually, it's a little under 21%. The fact being is there's no difference in the concentration of oxygen at any level in our atmosphere, all right, or any altitude. What changes is the barometric pressure, and we'll talk a little bit later on about pressure and how that affects the exchange of gas. So exhaled air contains 16% oxygen. So when you exhale, you're still exhaling 16% oxygen. That means that only about 5% of what we brought in did we actually have gas exchange take place on. Why? Where's the only place where gas exchange takes place?
Alveoli.
The alveoli. So at the alveoli, so everything else that sits there, everything that's sitting in our bronchioles, everything that's sitting in our bronchus, in our trachea, in our oropharynx, our nasopharynx, in our mouth, in our nose, no gas exchange is taking place. It's just sitting there, just chilling. So when we start to breathe out, then we're going to breathe out that 16%. 4% is about CO2, the rest is nitrogen and other gases. So again, what's the difference between ventilation and respiration? Just very quickly.
Ventilation is the movement of air in and out. Respiration is the gas exchange.
Very good. Very good. Okay. So respiration, diffusion. What is diffusion? All of you should know this.
It's the movement of substance from a higher concentration to a lower concentration.
That's right. It's a movement of a gas from a higher concentration to lower concentration. All right. Everything in the world wants to be equal. All right. It's just nature's law. If I have 5 of one thing over here and I have 5 of another thing over here, all is well in the world. Okay. If I have 12 of one thing over here and I have 6 of another thing over here, that's not good. So what are we going to try to do? We're going to try to get 9 on one side and 9 on the other to make our total of 18, because 12 and 6 is 18 and 9 and 9 is 18. but everything is equalized out. Right? And that is what diffusion is. And when we talk about it, the lungs, that's what's going on. We want the CO2 levels to equalize out to what the O2 levels are. Okay? So we want everything to balance out. So we have lots of alveoli, which cause a greater surface area. So that's why when we look at these little bunches of grapes, and if we were to actually expand them out, we have a lot of area for gas exchange to take place. So the surface that's available for ventilation is what we call V. Okay, it's represented by V. Okay, the amount of blood flowing through the alveoli is Q. Okay, so what I'm bringing up to these two definitions of defining what V is and what Q is what we call a VQ mismatch. All right, all of us right now, hopefully, are having a VQ equilibrium. Everything is equal. Everything is right. Our ventilation matches what our alveoli is using. All is well. Okay. When we talk about patients that are sick, we have a VQ mismatch oftentimes. And a VQ mismatch can be a reduction in the alveoli for gas exchange or based on the limited amount of blood flow. So if I lose my alveoli, like in a patient that has, say, emphysema, I am going to have a VQ mismatch, but it's going to be based on the V. Okay, on the ventilation. I don't have the surface area for that ventilation to take place. Now, when I talk about Q with a VQ mismatch, the limited amount of blood flow. So let's think about a patient that has a pulmonary embolism and blood flow is being interrupted to the lungs. Am I bringing in enough blood through there to circulate through the alveoli for gas exchange? No. So I have a VQ mismatch. This side it's on the Q side. Okay. What about a patient that's got both COPD, like emphysema, and has a pulmonary embolism? We have a VQ mismatch still? Yeah. It's a bad thing then, though, because we're talking about a double VQ. Okay. So everybody kind of clear? You guys understand what I'm talking about with a VQ mismatch? It either has to do with the amount, not having enough surface area for the alveoli for gas exchange to take place, or I don't have the amount of blood flow that I need to for gas exchange to take place. And that's what we talk about with a VQ mismatch.
So if you have like a tension pneumo and it's pushing, say, on your right lung and collapsing it, is that going to be a V mismatch?
Absolutely. That's a VQ mismatch on the V side. Very good. So what he just said is basically a tension pneumothorax with the pressure on the lungs, preventing the expansion, which interferes with the ventilation. So that's going to cause a VQ mismatch on the V side. There we can see another view of the capillary-alveolar relationship. You can see the rich capillary beds that surround the alveoli for that gas exchange to actually take place. So chemical control, remember the brain controls breathing. The nerves act as sensors for the level of CO2, our chemoreceptors in the blood and CSF. And what they monitor is the PaCO2, which controls ventilation. If my CO2 levels get high, it makes me breathe faster. If my CO2 levels get low, it makes me breathe slower. Absolutely. Okay. We have our hypoxic drive. That's the backup system. What is a hypoxic drive?
We breathe because we need oxygen.
We breathe because we need oxygen, okay, rather than breathing on CO2. We all, to a degree, have the ability to have a hypoxic drive right now, okay, if something happens with our CO2 levels. But realize our body is based on breathing off of what our CO2 levels are. Patients that have emphysema, chronic COPD, these patients at this point in time don't breathe based on the fact that they're how much CO2 they have, because they're always a little acidotic. What they breathe based on is, hey, my CO2 levels are low, my O2 levels are low, rather, my oxygen levels are low, I need to bring in some air. So whatever their normal range is, whatever they set their PaO2 to be in their body, and remember, what's normal to me is not normal to you, and what's normal to you is not normal to me. Everybody's going to be a little bit different. That's what's going to guide their breathing when we talk about a COPD patient. So when we have the buffer system, we can absorb or donate hydrogen ions. Remember hydrogen ions, if you remember from your lecture in intermediate school, and also you should have got a little bit of this in A&P. That is our buffer system is going to pick up or release hydrogen ions to adjust for it. Okay, but it's only minimal in the amount of work that it can actually do. Okay, but the buffer system works constantly. We either are going to donate a hydrogen ion if we're alkalotic, or we're going to pick up hydrogen ions if we're acidotic. Okay, so it can either shift to the left or the right. Respiratory system and renal system work with the bicarbonate buffer. Realize our respiratory system is going to fix this by doing what? How do we fix acidosis when we talk about the respiratory system?
Tachypnea.
Tachypnea. We blow crap off. What about when we talk about the renal system?
Pee it.
We pee it off, or we either hold on to bicarbonate or release bicarbonate. We're going to talk about that a little more later when we get into the ABG lecture, which is lecture number 2 for this. Okay, nervous system control, we have the medulla oblongata, and like I always like to point out in all of my lectures, contrary to what Colonel Sanders said in The Waterboy, that is not what causes anger and hostility in alligators. Okay, the medulla oblongata is our respiratory center in our body, and we have 2 nerve groups that we talk about. We talk about DRG and VRG, and we have the dorsal respiratory group. Alright, you've all heard of the pacemaker in the heart, which is the SA node. Well, the pacemaker for breathing is the DRG, the dorsal respiratory group. It is what's going to initiate inspiration. Signals are going to travel down the phrenic nerve to the diaphragm. Realize the phrenic nerve is an important nerve to know about. If you have a disruption of the phrenic nerve, you're going to have problems with ventilation. If something cuts off that phrenic nerve's communication to the diaphragm gets paralyzed. The diaphragm gets paralyzed, it no worky. It no worky, you no breathy. You no breathy, you die. Okay? That's enough ease for the day. Okay? Then we have the ventral respiratory group, which helps with forced inspiration or expiration as needed. Okay? That's what it's going to concentrate on and also aid us with the expansion of the lungs. We have the pons. In the pons area of our brain, we have the pneumotaxic center, which is going to shut off the DRG. All right, so which is going to suppress our breathing rather than forcing us to breathe. What the pneumotaxic center will cause us to have shorter and faster respirations. All right, the apneustic center is also found in the pons, and it stimulates the dorsal respiratory group, which is going to cause us to have longer and slower respirations. So we're going to have shorter and faster versus longer and slower. Okay. Then we have the Herring-Burrow reflex, which is kind of a cool thing, an important thing to have, because the Herring-Burrow reflex basically has our stretch receptors, which are going to prevent our lungs from being overinflated. All right, I want everybody really quick to take a deep breath in. Now take some more air in. Now take some more in. Try to do some more. You can't, because the Herring-Burrow reflex is preventing you from being able to take in any more. It's protecting your lungs from overexpansion. Because ultimately, just like a balloon, at a certain point, you put enough air in it, what's it going to do? Pop. Alright? So when we talk about ventilation, our lungs have approximately a 6-liter lung capacity for males. Females have roughly about a 5-liter lung capacity. If you're one of those people that shop at Bigger and Taller, you have obviously a higher lung capacity. If you shop at Baby Gap, you have a smaller lung capacity. We usually only breathe in about 500 milliliters if you think about that. Okay? Think about it, what you're breathing. Now, right now you're thinking about breathing. So now you're thinking about, okay, I'm going to breathe, breathe, breathe. No. Think about what your normal breath is when you're just sitting there. Or what somebody else is doing, your neighbor's doing. They're just breathing in a little bit, because we're only breathing in about 500 mLs. Okay? That is our tidal volume. Everybody is going to have a different tidal volume. We have our inspiratory reserve volume, and we have our expiratory reserve volume. Our inspiratory reserve volume is the fact that we breathe in, the more air we can breathe in. So take a deep breath, and then breathe again. That's your inspiratory reserve volume. You have a little room for a little bit extra air to come in. Same thing with expiratory reserve volume. Exhale. Now exhale some more. For the smokers in the house, and it's why you probably don't have that great of an expiratory reserve volume. You probably don't want to go see the RTs down the hall because you're probably not going to be happy with your PFT results or your pulmonary function test results. Now residual volume, and then we have dead space. We already talked about dead space. Dead space being all of the extra air that we have in our trachea and our oral pharynx, nasal pharynx. The crap that just sits there, that doesn't have gas exchange taking place. It's there. It's dead space. It doesn't do diddly squat for us. Okay, but unfortunately, you've got to have dead space because if you don't have dead space, how are you going to actually get the air into the lungs? You're not. Okay. So you've all heard, so tidal volume roughly is roughly around 5 to 7 cc's per kilogram of ideal body weight. So for me, that does not mean that we're going to base that on the fact that I weigh around 400 pounds. Okay, what we're going to base that on is the fact that I should weigh 190 pounds if you go by the textbook. So 190 pounds divided by 2.2 to convert to kilograms equals us to, let me work the math out for me here.
About 87 kilos.
Okay, 87 kilos times
7.
Let's go with 5. Always start on the lower end, work your way up. So 87 times 5 is, oh come on, you should be able to do that in your head. And you call yourself a paramedic student.
435.
435? Are you sure it's 435? 400, yeah, about 400. 435 sounds good. We'll go with it. All right. So roughly, that's what my tidal volume should be. Okay. So, so that is, yeah. But remember, everybody's going to be a little bit different. I'm probably going to have a higher tidal volume than that, truthfully. But that's a good starting point for us. And tidal volumes are going to become really important for us when we start talking about ventilators. Okay. Right now, what's our best indication of good ventilation?
Chest rise.
Chest rise and fall. Okay, so we have our minute volume, and minute volume is if we take our tidal volume times our respiratory rate, that's what gives us our minute volume. So how much air? So we have 430 something times, I'm breathing 12 times a minute, so that's 4,030, so about a little over 5,000 roughly is my minute volume. So that means every minute I'm bringing in about 5 liters of air. Okay, so almost almost 2 3-liter Coke bottles. Okay, so everybody clear on that? Clear as mud. All right. So realize that normal breathing should be easy and non-labored, adequate rate and depth. We all know this: regular rhythm and pattern, audible breath sounds on both sides of the chest, regular rise and fall movement on both sides of the chest, movement of the abdomen, and it should be silent and effortless. We're going to play with this in lab when we do airway assessments. Okay, normal rates, you should know these. I guarantee you'll probably see this on a test, probably multiple exams throughout your career. Adults is 12 to 20, child is 15 to 30, and infant is 25 to 50. All right. Little humor for you there to read. All right. You know, you now have an important role in the natural selection process. Besides knowing how to treat, you have to decide who to treat. Okay. So there's your first little funny rule of being a paramedic. Okay. Inadequate breathing. Okay. Awake, alert, and talking patients, we know that they have an airway. If they're awake, alert, and talking, they've got an airway. Labored breathing, looking for accessory muscle use, like we can see on this guy. He definitely has accessory muscle use. Bradypnea, or slow breathing. Tachypnea, fast breathing. Retractions. What are retractions? I call it second China. You can see everything going into the ribcage getting sucked in. Okay. Pale or cyanotic skin. Cool, clammy skin, tripoding position. Realize when we talk about cyanotic skin, if you find the Smurf, let me know about it. I'll come wherever you're at and look at it. Because realize Smurfs are not cyanotic. Smurfs are blue. Cyanosis is a pale gray color. Okay. Agonal gasps. What are agonal gasps? Okay, agonal gasps would be when the patient's just laying there going.
Fish out of water.
Kind of like a fish out of water. it means we need to ventilate them, okay? It usually means we need to do some type of intervention, okay? How many of you guys have heard of Dalton's law before? Well, now it's time to start getting into a little bit of the gas laws. Dalton's law of partial pressure states that the total pressure of a gas and the sum of the partial pressure of the components of the gas. At sea level, the total pressure of air is about 760 millimeters of mercury. The major components of air are nitrogen, 78.6%, oxygen, 20.8%, carbon dioxide, 0.3%, and water vapor, 0.5%. So, I'm going to do this. So, I have from your cohort of classmates here, I have Jacob Haynes, I've got Derek Cox, and I've got Richard Short, and I've got me, Jesse Davis. Alright, so this is what we're going to do here. So, you guys all probably saw each other on the first day of class or during paramedic orientation. We know that Derek's a pretty big guy. So Derek counts for 25%. I'm another pretty big guy, so I count for 25% as well. Alright, so we've got Jacob over here. Jacob counts for, well, let's rephrase that. This isn't going to work out how I did it. Okay, everything's got to equate to 100%. So Derek counts for 30%. I count for 30%, so that's 60%. That means that Jacob, he counts for about 20%, and Richard counts for another 20%. So, if you add us all together, in this room right now, we have 100%. Alright? 30 plus 30 is 60, plus 20 is 80, plus another 20 is 100. So that's Dalton's law. And all gases are that way. There has to be 100% always. That's nature's law. So, when we look at our atmosphere, we have 78.6% nitrogen, followed by 28% oxygen, 0.3% carbon dioxide, and 0.5% water vapor. And for those of you that want to crunch the numbers, that equates out to how much? 100%. Okay? At higher altitudes, the total air pressure is lower than at sea level. So realize that the air pressure is lower than at sea level. So because of this, even though the percentage of oxygen and all the other gases remain the same, the partial pressure of oxygen decreases. So what does that mean? The ability for oxygen to diffuse lessens. So that's why if we go from Eunice, New Mexico to Ruidoso, New Mexico, and we go try to run up a mountain, what are we going to be doing?
Rolling down the mountain.
Because we're going to be huffing and puffing because we're not adequately able to have that oxygen diffuse. Okay? But the concentration has not changed. It's the pressure due to that change in altitude. Increasing the percentage of oxygen that a patient breathes is one way to increase the delivery of oxygen to a body's cells in times of respiratory and circulatory compromise. So we increase the percentage of oxygen. So we hook them up, bump them up to 100%. We have 100% oxygen they're breathing in now, so hopefully more of that's going to be able to diffuse across. Okay. So there you can see another little example of the partial pressure and the percentage in air of gases at sea level, courtesy of the AAOS Airway Management book. So respiration is the process of exchanging oxygen and carbon dioxide, and it's done at diffusion. Alright, so again, we're going to have that movement of gas from an area of high concentration to an area of low concentration to create that equilibrium fact. So if I have 9 on this side and 3 on this side, what am I going to do?
Diffuse 3
to make
6.
6 on each side of the equation. Everybody understand that? That is diffusion at its best. Okay? If you don't understand diffusion, write it down. And then what I want you to do is bring it to me whenever you come for lab, and that way we'll do a little bit of a lab demonstration on what diffusion actually is. Alright? So the movement of gases always follows the pressure gradient. The oxygen molecules are ultimately delivered to the mitochondria, and the mitochondria, remember, is the powerhouse of the cell, where they're going to be used in the Krebs cycle to convert glucose to energy. That's why we breathe oxygen in, ladies and gentlemen, so that we can have that whole conversion in the Krebs cycle. So really, truthfully, the whole reason why we breathe oxygen in is to get rid of carbon. So in with oxygen, out with carbon dioxide. And there you have the myth, or the truth, or whatever you want to say, the whole story of why we breathe oxygen. Two types of respiration occur in mammals. We have external respiration, the exchange of oxygen and carbon dioxide between the blood and fresh air at the alveoli level. That is external respiration. Then we have internal respiration, which is the actual respiration that takes place at the cellular level. So at your big toe cell right now, you've got oxygen and CO2 exchange taking place. Right now in your big toe. Right now in your earlobe. Right now in your heart. All of this is taking place. That is internal respiration. All right, here you can see a little diagram. If the diagrams help you with internal and external respiration, and you can see how that pressure gradient is just determining that actual exchange that takes place. Fresh air inspired in the lungs contains about 21% oxygen, 78% nitrogen, and 0.3% carbon dioxide. So we'll talk about this a little bit later. So if we put somebody on 100% oxygen, okay, they're on 100% oxygen, and they're breathing that in and out, or we're ventilating them with 100% oxygen, guess what we're going to do? We're going to do what we call a nitrogen washout. Okay, and we cause that nitrogen washout to take place. That's going to make sure that their SATs are a lot better. And that's important when we talk about intubating patients and managing their airway. If we're going to do invasive airway management techniques, is causing that nitrogen and replacing that nitrogen with actual oxygen. So that way we don't have that other junk in there. Okay. So the components of the inspired air is going to be dissolved in the surfactant, which is therefore going to cause during external respiration. Okay, that's where the plasma and hemoglobin are going to be oxygenated in the pulmonary circulation and returned to the heart to be pumped to the rest of the body, so that way internal can take place. Hemoglobin, about 97% of the oxygen transported throughout the body is bound to hemoglobin. Okay, and hemoglobin is what?
So part of the blood that oxygen binds to.
Yeah, it's a part. Hemoglobin surrounds the red blood cells. Okay, it's like a glob. Just think about it. Heme is protein. Glob meaning glob of it. Okay, and that's what it looks like. If you got an electronic microscope and you looked at a red blood cell with hemoglobin on it, you're gonna just see this big old glob of crap surrounding it. Okay, and it's kind of like a spider web basically, and that's what grabs onto that oxygen and holds onto that oxygen and takes it. But hemoglobin is an iron-containing molecule located in the red blood cell that has a great affinity for oxygen molecules. However, it's got a greater affinity for what?
Carbon monoxide.
Carbon monoxide. It would much rather pick up carbon monoxide than oxygen. Okay, I guess O2 is too heavy compared to CO. Okay, now, why is blood red? Well, I can hear the crickets chirping tonight. All right, blood is red. Okay, let me ask you this question. If you take a piece of iron and you leave it outside, what's going to happen to it?
Rust.
It's going to rust. And what's another name for rust?
Oxidation.
It's going to oxidize. And that is why oxygenated blood is red, or brighter red, rather, and deoxygenated blood is a deeper color, okay, because oxygenated blood has been oxidized. The hemoglobin is oxidized. When the oxygen's off, it is deoxidized. That kind of makes sense? Okay. As blood passes through the capillaries, the circulatory system, the hemoglobin picks up the oxygen molecules that are dissolved in the surfactant. Under normal conditions, we got about a 96 to 100% hemoglobin receptor sites contain oxygen. A hemoglobin molecule that's fully loaded has 4 oxygens on it. That's a fully loaded hemoglobin. Okay, so that's how many seats are on the bus. So yeah, I guess you could say it's a short bus. Okay, so it's riding around. It's got 4 seats on there. That's when it's fully loaded, and that's what we're trying to do. So that's when we have a patient that's got 100% O2 saturation. That means they should have 4 hemoglobin or 4 oxygens riding around on their hemoglobin. But what happens if we have less buses than normal? No, our SATs are going to still be 100%, but are we really 100%? No, because our buses aren't there, so we're not really, we have 100%. Our buses are fully loaded, the buses that we have, but we don't have enough buses to deliver everything that we need to, okay? So, under normal conditions, like I said, that's 96 to 100%. The percentage is known as arterial saturation of oxygen, which is an SaO2. So dissolved oxygen, well, we get it. Some of it gets attached to the hemoglobin. A little bit of it is actually going to be just dissolved in the plasma. Okay, and that's about 3% of the total oxygen transported to the cells. All right, and what we call that is the partial pressure of oxygen in inspired air, which is going to be expressed as PaO2 when you learn about ABGs. That's a PaO2. Okay, so dissolved oxygen normal value at room air is approximately 100 millimeters of mercury. We're not talking about percentages here. We're talking about looking at what the normal value of dissolved oxygen is. While breathing 100% oxygen, a patient's PaO2 can increase to 300 to 400 millimeters of mercury. Okay, what we call that is hyperoxygenation. Okay, they are hyperoxygenated. Okay. The additional oxygen can improve the patient's ability to supply oxygen to meet the body's demands because it's ultimately readily there for the hemoglobin to pick it up or for it to be utilized and sucked into that cell and to be used. Okay, so that is what we're talking about with dissolved oxygen. So does everybody understand that we're talking about PaO2 here, not SaO2? Because SaO2 is your saturation of oxygen, which is what we get off a pulse oximeter. What we're talking about right now is if we drew somebody's blood gas and actually got what the actual pressure value of oxygen would be in their actual blood. So again, internal respiration, the exchange of oxygen and carbon dioxide between the systemic circulation and the cells in the body. And that's what the whole process is. We're here to do this in an aerobic cycle. That's why we breathe air. Aerobic metabolism. It's what produces energy, carbon dioxide, and water. It's what our body's designed to do. In comparison to, you probably all heard of anaerobic metabolism, which happens from time to time. We induce anaerobic metabolism when we work out, okay, which produces lactic acid. Also, patients that are in shock and that are hypoperfused, they will go into anaerobic metabolism, which is going to cause as well. So, anaerobic occurring in the absence or without oxygen. Most cells can survive short periods of time under anaerobic condition. Eventually, without adequate supply of oxygen, the cell cannot meet the metabolic demands and will die from the accumulation of lactic acid and other toxins in the body. Everybody good so far? Okay. All right. So you can see here, we'll continue on. Arterial blood and high in oxygen reaches the capillary level. The interstitial fluid, the oxygen follows the diffusion gradient. So what are we talking about with following the diffusion gradient? When the mitochondria, so what are we talking about with a diffusion gradient?
It goes to areas of lower concentration.
There you go. Thank you. When the mitochondria use oxygen to convert glucose to energy, carbon dioxide, the main waste product, accumulates in the cells, and that's what's going to, again, we get the carbon as we go through the Krebs cycle and ATP, and is used for energy. We have carbon as a waste product. That's what's going to be picked up and utilized and sent off and sent out. Okay. Carbon dioxide is transported from the cells of the lungs and exhaled in three ways. It's either going to be dissolved in plasma, which is about 9% of it. It's going to go out as carbonate hemoglobin, which is about 24%, or it's going to go as bicarbonate about 67% of the time. Okay, and realize if you know a little bit about chemistry, and we'll talk about this in the ABG lecture number 2 here in a minute, we talk about carbonic acid and bicarbonate. All it is a matter of changing a carbon and a hydrogen along the formula. And just by doing that simply, we get that buildup. Okay, or we get bicarbonate switching to carbonic acid. Okay, but that is how we're going to get rid of that CO2. So most of it, again, is going to be transported just in the plasma as bicarbonate. Okay, a little of it is going to be carboxyhemoglobin, which we also sometimes, a lot of times, refer to as the oxyhemoglobin. Okay, so again, it can reversibly bind to carbon dioxide. Carbonate hemoglobin transport carbon dioxide from the cells to the lungs to it out of the body. Bicarbonate ions, when we talk about that, 67%. Carbon dioxide, CO2, reacts with water, H2O, to form carbonic acid, which then dissociates, leaving bicarbonate ions, HCO3. Okay, that's bicarbonate. Okay, The ions are important for the components of the acid-base balance of blood and body fluid. So again, it's going to constantly change because we know CO2 is acidic, right? Okay, so we have CO2 in water, we've got an acid. We change that structure just a little bit and we have bicarbonate now and oxygen. What do we got? A base. So that's how that whole thing works, and that's how our body constantly keeps in check our acid-base balance. Okay. So the oxyhemoglobin dissociation curve. Approximately 95% of the protein in red blood cells is hemoglobin. Okay. So if we took all the hemoglobin, or if we took all of our cells and we let them settle down and let them set, we get what we call the hematocrit, and that's the concentration of all of our red cells settling down in the body. So normal value for hematocrit, again, that hematocrit being the concentration of those red blood cells, is 45 to 55% for men and 37 to 48% for women. So that's, again, a concentration of all your red blood cells. If you just let your blood, if you drew a tube of blood, let it sit, everything that settles down to the bottom is the hematocrit. Okay, it's the cells. All right. So the hematocrit is going to indicate the percentage of red blood cells within a whole blood when the sample is spun in a centrifuge. Okay. So 1 molecule of hemoglobin binds with 4 molecules of oxygen, like we've already talked about. So the percentage of the receptor sites that are occupied by oxygen is expressed as SaO2. So if they're all fully loaded down, we've got a 100% oxygen saturation. The oxygen dissolved in the plasma, however, which we still have some of that, is going to be denoted as PaO2. Is there any way we can check PaO2 on the truck? No. All we can check is SaO2. Okay? But realize that the SaO2, or the saturation of oxygen, is going to be proportional to the partial pressure of oxygen. They're going to be proportional. Okay, so if you got a high SaO2, you're going to expect to have a high partial pressure of oxygen, and vice versa. Okay, so the oxyhemoglobin dissociation curve. This blows lots of people's minds. It freaks people out when we talk about the oxyhemoglobin dissociation curve. It's really not that bad. But what it is it's a relationship between SaO2 and PaO2 by the oxyhemoglobin dissociation curve. Under normal conditions, a PaO2 equals 105 millimeters of mercury. The SaO2 is 98%. Okay, so that's what we're talking about there. So at 105 millimeters, so if you go down over here on the PaO2 and you look over at 105, roughly where 105 is going to be at, you're going to notice that if you go up to where SaO2 is, you're going to see that SaO2 is somewhere around 98%. Okay. If you look at the graph, different graphs are a little bit better. This isn't the greatest one in the world. Okay. The ability for the respiratory system to supply oxygen exceeds demand of normal resting conditions. Okay. When metabolism increases, our demand for oxygen increases. Okay. And venous blood is going to contain less oxygen. Think about that. Okay. If you run, you need more oxygen. You breathe faster. So that means you're going to consume more oxygen. Okay, all of us sitting right now are going to have fairly high levels of oxygen in our veins because we're not utilizing all of it. We don't need it all. However, we go out there and we start running around, okay, we're going to start consuming that, so we're going to have less in our venous system at that point in time because we're utilizing that. And this is going in and building into what the oxygen curve is going to tell us. As the blood circulates to the tissues, PaO2 is going to drop. The oxygen is going to be released from the hemoglobin, is going to be available for cellular respiration. So as we go around, as metabolism takes place, we drop off oxygen. Oxygen detaches from hemoglobin and we utilize it. Does everybody follow me so far? That's how it happens. Okay. The lower our partial pressure of oxygen in the tissue, the more oxygen is unloaded into the interstitial fluid. Okay. So as our plasma levels of oxygen drop, our hemoglobin is going to start dropping oxygen off into the plasma, okay? Because it's going to notice that it's dropping that. So hemoglobin has the ability to change how tightly it holds on to oxygen in terms of the change in metabolic conditions, okay? When metabolism is high, we produce more CO2, correct? Which makes us
Acidotic.
Slightly acidotic. When our metabolism is slowed down, or we have other changes taking place in our body, we don't have as much CO2, which is going to make us alkalotic. This is going to affect the oxyhemoglobin dissociation curve. This is going to cause a shift on that curve. And this is what it's all about and what you need to understand. So a shift to the right causes the hemoglobin to give up its oxygen faster and earlier. A shift to the left has the opposite effect, which means it's going to not allow us to let go of the oxygen. The oxygen is going to take tightly wound onto that hemoglobin, and we're not going to let it go. A shift to the right, we just drop it. Shift to the left, we hold on to it. Okay? So, someone that is acidotic, okay, meaning that they've got a pH of below 7.35, they can't hold on to oxygen. We ventilate them, we saturate their hemoglobin, hemoglobin's going around, floating around. We get out here to the, it's traveling through the bloodstream, it won't stay attached to the hemoglobin. It falls off and gets into the plasma. Okay, so we lose it. We lose it faster than we can use it. Okay, in compared to somebody that's in an alkalotic state, meaning they have a pH above 7.45, in that case, we saturate their O2, their hemoglobin with oxygen, and we have them fully loaded. It gets down there to the big toe cell to drop off oxygen. It won't jump off the hemoglobin because they're alkalotic. So acidotic, the oxygen's falling off the hemoglobin. Alkalotic, we can't let go of the oxygen. Does everybody understand that? And that is what the oxyhemoglobin dissociation curve is talking about. Okay, those changes. A shift to the right, causing us to give up the oxygen faster and earlier than we need to in an acidotic state, or a shift to the left in an alkalotic state, meaning we can't get rid of it. We're holding on to it and we just cannot drop it. So alkalosis causes a shift to the left, and acidosis causes a shift to the right. Okay. Fetal blood lacks 2,3-DPG, and if you want to know what TPG is and want to spell it all out, you can look it up. It is a protein molecule containing phosphorus, and it's what its purpose is to allow us to actually hold on to oxygen in the allows us to actually hold on to oxygen out of that hemoglobin. So a patient that has a decrease in 2,3-DPG causes oxyhemoglobin to shift to the left, okay, increasing the hemoglobin affinity to oxygen. Okay, this is what allows us to draw, or a fetus to draw blood from the mother's circulatory system. Okay, so again, we're going to hold on to it. Does that make sense? So if we have a whole bunch of 2,3-DPG, we're going to just be dropping it like it's hot. If we don't have enough of it, we're just going to hold on to oxygen, which allows us to sustain it longer and keep a hold of it. Okay, that's very important when we talk about neonates. Okay, that's how the whole neonatal circulation works. Okay, especially when they're first born and we talk about PD. Okay, so hypoxia, inadequate supply of oxygen to the tissues. 4 main causes. They're hypoxemic hypoxia, which means we're just not breathing in enough oxygen. There's anemic hypoxia, which means, well, we don't have enough buses to carry the oxygen around because there's red blood cells missing. We have stagnant or ischemic hypoxia, which means the blood's just sitting there and we don't have actual gas exchange taking place, which makes us hypoxic. And we have histotoxic hypoxia, like when we talk about cyanide poisoning, with the prevention of the actual gas exchange. We have methemoglobin being created, and that methemoglobin not carrying oxygen, so therefore we become hypoxic. Okay, so hypoxemia, decreasing the amount of oxygen in the bloodstream. Number of conditions: respiratory arrest, airway obstruction, breathing air containing inadequate oxygen, pulmonary edema, not to be confused with pulmonary demons, and obstructive diseases. Okay. Anybody that has a hemoglobin saturation below 96%, and that's not necessarily based on an SaO2, but an actual blood gas, we're going to consider them to be slightly hypoxic. Okay. Hypoxemia is very easily corrected most of the time, though, is it not? What do we give them? Some oxygen. Okay. Realize that anemia is a decrease in the number of red blood cells, a decrease in the hematocrit value, significantly alters the oxygen carrying capacity of the blood. Most common causes of this is going to be iron deficiency, is the number one cause. Blood loss, in and of itself, causes anemia. Genetic disorders such as sickle cell anemia. Realize that all of the sickle cells do not have the ability to carry oxygen. Okay. Stagnant hypoxia, low course systemic interruption of blood flow. If the heart stops completely, all the tissues are going to deplete the oxygen. So the blood just sits there, and we're not actually able for oxygen exchange to take place and carbon dioxide change. Histotoxic, ability for hemoglobin to release oxygen. Relatively uncommon, except when we're talking about those toxins, like cyanide and other things that are going to prevent the actual hemoglobin from doing its job. That's about the time we see this. That is A&P in an hour and 5 minutes for review. If you have any questions, please email me, or better yet, post them on the discussion board, so that way your fellow students can benefit from the questions and get ready for ABG interpretation up next.